Welcome to Beyond Your Balance Sheet from the Sedora Group of Steward Partners Global Advisory. I'm Laura Knoy. Today, making end-of-life decisions with compassion and knowledge. Our guest is Patricia O'Conner, a nurse practitioner who is board certified in hospice and palliative medicine and adult medicine. She's been involved in this field for more than 40 years and is author of the book, Navigating Life's Final Journey: Conversations, Choices, and Resources. Patricia, a big welcome to Beyond Your Balance Sheet. Thank you for being here.
Thank you for having me, Laura.
So let's focus, if we could please, on that all-important word in your title, conversations. When it comes to these end-of-life decisions, Patricia, what conversations are people not having right now with their medical providers?
Well, when people have conversations with their medical providers, they sometimes come out not knowing exactly what's going on. They don't talk about dying using the word dying. They don't talk about end of life because they try to focus on what they can do, not what's beyond their ability. They're not saying the word dying, and they're not talking about a person's wishes at end of life.
It's all about that cultural taboo, isn't it?
Yes, it is.
So why aren't these conversations happening, Patricia, beyond the cultural taboo? What about the sort of medical code of do your best, do no harm, try to cure the person?
Well, and that's still the code. And medical providers are trying. They really, really are. But time is so limited. As most people are aware, there's less medical providers per person now. And time in the office is limited. Comfort, people don't have comfort. It's not always taught or practiced in their learning environment. It's hard for people to acknowledge what they can't fix because all of their focus is on fix, fix, fix. Many of them are worried that they'll take away hope from an individual without being aware of the hope that they can give when they begin to have honest conversations. And one final reason is that many people don't even know their primary care providers because they've been switched so often. So without that trust, it's hard to have that intimate level of conversation.
Wow, pick up on what you just said, Patricia, because that's so interesting that medical providers don't want to take away hope, saying, look, sir, you probably only have 6 months left to live. You say that making that statement in a different way, obviously, may actually provide hope. So give us a little more there.
People know inside of themselves that they're very sick. People know, if you ask them, they know their time is limited. And for some people, they are hoping their time is limited because life is so hard. And so their hope is in the here and now, not in the months from now or years from now, but in the here and now. So if they have the truth, then they can know what they can count on and what plans they can make that would be hopeful to come through.
You know, there's a story in your book that just illuminates just what you talked about, Patricia, that I think it was a man, got a message that he didn't have long to live. And that knowledge was actually a gift. He had the gift of a very special summer. Tell us about that, Patricia.
Yes. So one woman, I remember a conversation after her husband had died. He had been very sick. They were both my patients. It was when I was a primary care provider. And in knowing the truth about his illness, that it was irreversible, that he couldn't get better, they chose to go on the hospice program. And what she came to me saying after he died a month or two, she said the greatest gift that they were given was a summer. They had a summer to enjoy each other, the beach, their family, and they didn't have medical appointment after medical appointment. They weren't feeling sick from treatments, but their time was theirs to spend in ways that were memorable and meaningful to them.
Yeah, I mean, it's a beautiful story. I'm kind of getting choked up hearing you tell it again. What about family conversations, Patricia? What family conversations need to take place and are not often taking place?
Well, there's that whole still dynamic about not talking about dying. And that's not happening. So the truth's not coming out. But if we can start a family conversation with saying, what are your hopes? What are your fears? what do you think is going on? Then the truth will come out if we're patient and we stay with the moment instead of saying, no, 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 you're going to get better. So people, unfortunately, are not talking about their advance directives. They're not naming healthcare agents, and they're not talking about what quality time means to them.
Well, that gets us into all the end of life documents that you outline in the book, and it's very useful. And I want to go there in a moment. But hospice care, we should talk a little bit about that, just in terms of defining, Patricia, what it is and what it isn't, because you've said that there's a lot of myths or misunderstanding around what hospice care is. So go ahead.
So, first of all, hospice care is not just for the imminently dying. A lot of people, if you mention the word hospice, they get terrified because they think that means they're imminently dying. Hospice care is for people whose provider has said to them, it wouldn't be a surprise if you were to die in 6 months. Actually, the provider needs to say that to Medicare. And the patient would say, my goal is to enjoy the time I have left with as much quality as I can have without medical prolongation. So what hospice gives is symptom management and efforts to make that time the best quality it can be, where nurses come to the house so you don't have to be out for medical appointments all the time. And you have 24/7 support, which in my experience, that's one of the most important things. When families are trying to take care of very sick individuals, they need somebody, they need a person on the other end of that phone anytime during the day or night.
So extensive support, extensive comfort, extensive professional knowledge, and Medicare covers it, Patricia, is that
And
right?
Medicare covers it. And that's something that surprises people, that this is covered by Medicare. And you don't have to die within 6 months. People come on and off of hospice, and we call it graduating. If their condition stabilizes, sometimes when people get on hospice and their symptoms get controlled, and they have less anxiety because there's no unknowns, they get better. And so they stabilize and they go off hospice for a little while, and then they can come back on it again.
Just the going back and forth to medical appointments alone can be draining and taxing and wearying. I can imagine that in and of itself would be a gift.
It is a gift. And sometimes the medical appointments and the medical treatments that are intended to help take away strength. And so that strength that you only have so much strength. I would say to people, you have 12 teaspoons of strength to use for today. How do you choose to use them? And each day, if you use 15 teaspoons, then the next day you're going to have less. This is when you're very ill. And so if you use 12 teaspoons going for your lab work and the doctor and imaging, you've got none left to go to your grandson's birthday party.
That is such a great analogy. I'm so glad you presented it that way. What's the reaction from patients when you talk to them about these choices, when you talk to them about the resources that are available? Because granted, when you say the word hospice, people do, some of them say, no, that's not for me, because they don't want to talk about dying. So I'm just wondering how you present these choices and what people's reaction is.
Well, I first ask people, Laura, what their goals are. And then from that question comes the conversation. So, for example, a gentleman I remember saying, I asked him, what is quality life? And he said, if he cannot mow his back 40, drive his tractor and mow his back 40, don't keep him going. Allow him to die. And so then you would say hospice would be indicated when he got too sick to mow the back 40, that he didn't want anything prolonged. So asking that question, what's important to you, has a natural consequence in talking about, well, here's the options of how you get that. And so if you go about it from the way of, I'm looking at programs that might help meet your goals, it's less scary.
Sure, and the patient says, oh, go ahead, Patricia. Yeah.
Well, some people think hospice is only for cancer and are very relieved and thrilled to know that it's for more diseases than cancer.
I'm guessing it's a huge relief for people to be asked what their goals are and to be told, I can help you get there.
Yes. Yes. And just to be able to be asked and to speak honestly about what they are and not be shamed for, it's not the goal to live as long as possible. It's the goal to live as well as possible.
Even
People
though that
have a
may
right
be the
to.
goal. Yeah, their medical provider may have that goal, their family may have that goal, but the actual person may say, no, I'd rather have the summer with my wife. I'd
Yes.
rather have the chance to go on that one last trip. So, this gets us right into, Patricia, the documents surrounding end of life decisions. And many people may be familiar with some of them: living wills or durable power of attorney. These documents supposedly help patients and their families have more of a say when they encounter the medical system near the end of life. Could you just please give us a list of some of the key documents and what the purpose of each one is? There are a lot, but let's go through them.
Well, there's a couple of legal documents and they're advanced directives. The two parts of that is a living will and a durable power of attorney for healthcare. The durable power of attorney for healthcare is a document whereby you state who you would trust to make decisions for you in a medical situation if you were unable to make them for yourselves. So if you got to a point where you couldn't make complex medical decisions, this would be the person you could trust to do it. Then the advanced directive other part is the living will. On that document is where you put the guidelines for what you would want that person to say. The important thing for people to know is in a living will, they're talking about what they would want if they were dying. They're not talking about what they want at the level of health they're at, making out that document. That's sometimes misunderstood. Then there are medical orders. So on a living will, you might say that if you were irreversibly ill and likely to die, you wouldn't want resuscitation. In order to have that honored by an EMT who might come into your home if called, you would need a medical order called a do not resuscitate.
Sure, a DNR, right.
DNR, right. That's a pink form. It's always been a pink form in New Hampshire that you put on your refrigerator, a card you put in your wallet. Then you can get even more specific by having something called a POLST. That's an acronym, POLST. It stands for Provider Orders for Life-Sustaining Treatment. That is for patients who are at risk of dying because of a serious life-limiting illness or a medical condition, including frailty, advanced frailty. So in a POLST, you're actually spelling out what level of care you would want to a much higher degree of specificity than you would in the living will. And that's a medical order. It's filled out with your medical provider, and it's taken with you to any institution you might go to.
So many documents. And when I read your book, I thought, oh, I'm familiar with 2 or 3 of these, but there are a lot more than that. Why are there so many, Patricia? And would it be easier for people if they were just one big document that summed it all up?
It would be so much easier. And when we talk in the Healthcare Decisions Coalition about these documents and how to make them easier, we all agree that the most important, the very, very most important, is the power of attorney for healthcare.
Okay.
If that document's filled out, at least you have identified who hopefully knows your wishes and would be able to speak for you. But it's complex because you need medical orders and you need legal orders. If a provider had the time to sit and fill out these forms with you, then it would be much easier. I have said in my role in palliative care, I would sometimes fill out all of these documents with a person during a visit. And it was just easier for them. It's hard for people to understand all the nuances.
Yeah, there sure are a lot. Well, and we all know that words matter. And in these difficult situations, lots of emotions, of course, word choice is incredibly important. You write, Patricia, that most people talk about prolonging life, quote unquote, but you would like us to look at it another way, delaying natural death. So, what happens when natural death is delayed through heroic efforts to prolong life?
Well, oftentimes prolonged suffering happens for the patient and the loved ones because comfort takes a back seat to prolongation. So a person might not get the pain medications that they need to get because there's too much worry about whether they might die or not. I just want to put a little note in here, though. When people are given medications for pain management with palliative care or hospice, it is done cautiously and it is not done to end somebody's life. But people are given pain medications to be comfortable. When we're delaying natural dying, a person can't be at home. They'll be in a hospital, which is not a place for intimate conversations. When we put a feeding tube in somebody because they can't eat or drink because they're dying, and they're in a hospital bed sometimes with their hands tied so they won't pull out that tube. We're robbed of meaningful time and communication. There's a physical, emotional, spiritual, and financial toll on everyone.
A financial toll on the family, a spiritual toll on the person and on the family.
Yes.
How hard is it to reframe this, Patricia, for patients or their families, this word switch that you suggest from prolonging life to delaying natural death? How hard a switch is that for people?
I think it matters how comfortable you are with being able to talk about dying. Because if you can't talk about dying and if you want to deny it exists, then it's very hard. But truly, all we need is presence, speaking the truth, listening, and teaching. And it is a relief for people when we do that. When the elephant comes out of the room, because we're speaking of death is inevitable. Death is inevitable. We've reached a point in your illness where we can't fix it anymore. We might be able to do little band-aids, but we cannot fix it. If you tell that truth, most people feel respected and everything flows from there. So we speak of the inevitability of the end of life and the choices that are available. But there isn't a choice that includes not dying, because that will happen eventually.
Right. Getting those conversations started, as you said at the beginning. You have been in this field for a long time, Patricia, and you're so passionate about it. What keeps you coming back to this work?
I believe we can do better. And I feel like in 40 plus years, I'm not sure how much better we've done. And in individual cases, we can do better when somebody has hospice or palliative care helping them. And there's some good relationships with PCPs that can help people at end of life. But on the whole, there's beautiful experiences that are missed because people are blocking exit ramps so that death is harder, and death is just a maze for people. And I know it can be good. And I think what keeps me coming back is I really want to help it to be good because I've seen how much better it can be. And it's just the nurse in me. I can't quit trying.
Well, it's good for the patient because they're comfortable, they're not in pain, they can maybe achieve those few last things they want to do. But it's also good for their families, I would imagine, Patricia, because they can feel good about the way it ended. Well, Patricia, it's really great to talk to you, and I really appreciate, all your thoughts about this sober but very important topic. So thank you very much for talking with us.
Thank you, Laura. Thank you for having me.
That's Patricia O'Conner, a nurse practitioner who is board certified in hospice and palliative medicine. She's author of the book, Navigating Life's Final Journey: Conversations, Choices, and Resources. Beyond Your Balance Sheet is sponsored by the Steward Group of Steward Partners Global Advisory. And I'm Laura Knoy. Thanks, everyone, for being with us.